Welcome again. We are going to discuss some of the salient aspects of one of the most enthralling and inquisitive autoimmune disease, that is rheumatoid arthritis. Although it is called as arthritis, it is a chronic systemic inflammatory disease actually. It is a systemic inflammatory disease characterized by symmetric polyarthritis and extraarticular manifestations. The age group of patients who present with rheumatoid arthritis usually 25 to 55 years. More common amongst females. 2 or 3:1 ratio, female is to male ratio is usually seen. What are the clinical features with which you should suspect that this patient could be a rheumatoid arthritis patient? So, patient presents with arthritis of small joints of hands and feet. What are the small joint? Usually the MCP, metacarpophalangeal joint, the PIP, the proximal interphalangeal joint, and the wrist joint is most commonly involved. But the distal interphalangeal joint is usually not involved. It is more involved in osteoarthritis and psoriatic arthritis. My teacher used to say that synovium is extensive in these small joints. The small joints are extensively covered by synovium, which makes them prone for immune attack against the synovium. That is why the metacarpophalangeal joints and the proximal interphalangeal joints are most commonly involved. Now it also involves the joints, tendons and the bursae. For example, flexor tenosynovitis in the hands. You know that the flexor tendons travel from the elbow down into the wrist and into the fingers. The flexor tendons are here and the flexor tendons have sheath. The flexor tendon sheaths are inflamed, causing flexor tenosynovitis, which may cause trigger finger. This becomes inflamed, this becomes fibrosed. Later, there is a trigger finger. Trigger finger means you cannot release it easily. You have to give some more pressure to release it, which is like holding a trigger of a gun. So, trigger finger. And there will be reduced hand grip. The hand grip will be reduced when these tendon sheaths are inflamed. So, it does not involve the joints alone. It involves both the joints, tendons and the bursa. So, another striking feature is atlantoaxial involvement of the cervical spine, which can even lead to subluxation of the atlantoaxial joint and neurological deficit, which is a life-threatening event that can take place in the RA course, rheumatoid arthritis course. So, we also see other joints involvement like knee arthritis, ankle arthritis, but the most common are small joints of hands and feet, which is the MCP and PIP in the hands, MTP in the legs, and wrist joint, shoulder joint, and less commonly the knee joint. Now, we will come to deformities. First, I discuss clinical features because at the earliest, if you catch this disease, if you understand that these clinical features point to rheumatoid arthritis and treat this disease, you will never lead the patient to deformities. So, all these are now very rare because of astute treatment by our rheumatological practitioners. So, what are the normal deformities we see in rheumatoid arthritis? Most of you would have seen in females in our families who have these deformities. One is ulnar deviation. Ulnar deviation, the hand is deviated towards the ulnar side. This is because the MCP joint, metacarpophalangeal joint, is subluxed towards the ulnar side, causing ulnar deviation. Then we have the swan neck deformity. What is the swan neck deformity? Swan neck deformity. All these deformities occur in erosive disease, destructive arthritis, erosive disease causing different deformities. One is swan neck deformity. What is swan neck deformity? Hyperextension of the proximal interphalangeal joint and flexion of the distal interphalangeal joint causes a swan neck. This is called a swan neck. Boutonniere deformity. Boutonniere deformity is exactly the opposite of swan neck deformity. What happens is there is flexion of the proximal interphalangeal. So, the swan neck deformity and the boutonniere deformity. The swan neck deformity comprises of flexion at the distal interphalangeal joint and hyperextension at the level of proximal interphalangeal joint. Whereas the botanier deformity is exactly the opposite, where there is flexion at the level of the proximal interphalangeal joint and extension, hyperextension at the level of distal interphalangeal joint. Then we have the Z-line deformity which occurs in the first CMC, and then we have the piano key movements of the ulnar styloid. This is the ulnar styloid process. This is where the extensor tendons arise, extensor tendons travel into the dorsum of the hand. So these extensor tendon sheaths, when they are inflamed, will cause instability of the ulnar styloid process, which is called as piano key movement. Like a piano key, the ulnar styloid can dip in between. So when you suspect that this patient could be a rheumatoid arthritis patient, you could look for a ulnar deviation, you could look for a swan neck deformity, you could look for a botanier deformity, you could look for a piano key movement of the ulnar styloid. Then we have the extraarticular manifestations that usually we see in rheumatoid arthritis. A patient who has at least one extraarticular manifestations is deemed to have worse prognosis, because only if the disease activity is high, we usually see extraarticular manifestations. The constitutional symptoms like fever, myalgia, fatigue can also be part of extraarticular manifestations of rheumatoid arthritis. Otherwise, you can see rheumatoid nodules, which are firm nodules, which are painless nodules that are fixed to the periosteum. That can be seen in extensor surfaces like the elbow, olecranon. All these areas can produce rheumatoid nodules. Sometimes rheumatoid nodules can also be found in the pleuropericardial surfaces too. Sjogren syndrome, otherwise called as secondary Sjogren syndrome, can occur in rheumatoid arthritis. You know the Sika syndrome, the dryness of the eyes, the dryness of the the destruction of the minor salivary glands, the destruction of the parotid and the submandibular glands causing dryness of the mouth. Such a kind of Sika syndrome can occur in rheumatoid arthritis also. Pleuropulmonary manifestations of rheumatoid arthritis. Patient can present with interstitial lung disease, or he can develop pleural effusions which are exudative in nature. Usually, in all systemic disorders, we find that the pleural effusion is usually transudative. But in rheumatoid arthritis, which is a multi-system involvement, the pleural effusion is usually exudative. Lymphoma can occur as a complication of rheumatoid arthritis. Now we are discussing about the genetics and risk factors of rheumatoid arthritis. There are several HLA genes, there are several non-HLA genes that can predispose to rheumatoid arthritis. HLA-DR4 is one of the predisposing factors. Other non-HLA genes like PTPN22 and PAD4 mutations can cause rheumatoid arthritis. Now coming to PAD4. What is PAD4? Now I would like to put forth a coined term called citrullinated peptide. What is citrullinated peptide? If there is a peptide here which contains several amino acids, out of which the last one is arginine. This arginine is being attacked or is being converted by several external agents like smoking, like some microorganisms like viruses, and one amine group, one NH3 amino group is removed from the terminal arginine. This arginine gets converted into citrulline. So smoking, microorganisms and other environmental factors can convert the terminal arginine the terminal arginine into citrulline by removing one amino group. This becomes a citrullinated peptide. This is alteration of a self-antigen into a foreign antigen. So this citrullinated peptide attracts a diverse variety of antibodies, autoantibodies, which is one of the main causes of rheumatoid arthritis. The synovium, the cartilage, the cartilaginous structures in the joint can all be citrullinated, and the antibodies against this can cause severe erosive disease of the joints, causing rheumatoid arthritis. So what is this PAD4? PAD stands for peptidyl arginine deaminase. So this enzyme mutation can cause multiple terminal arginine groups to get changed into citrulline containing peptides. This will attract a lot of immune injury causing, which can be a central part, which can play a central part in prognosis in the course of rheumatoid arthritis. So other risk factors which predict progression to severe disease in rheumatoid arthritis are smoking, high CRP, high ESR, high ACCP. What is ACCP? Anti-cyclic citrullinated peptide. We will discuss about that in later. Extraarticular disease and erosive disease at the onset. All these are risk factors for progression to severe disease. Why is this important? Why do you need risk factors for progression to severe disease? Because life of an RA patient is one which that involves a lot of pain. Slowly this pain progresses and the patient accepts the pain. Later the patient becomes deformed. The patient's joints become deformed. The patient becomes strictly within home. The patient develops multiple other comorbidities because of immobility. So to prevent all these, you should know that what predicts prognosis in RA, so that you can give potent immunosuppression at the very early beginning. So what are the risk factors for progression to severe disease? Smoking, high ESR, high CRP, high ACCP, extraarticular disease and erosive disease at the onset. Now coming to pathophysiology of rheumatoid arthritis. I am going to split this into two. What happens in the blood? What happens to our immune system? And what happens within the joint? Something that happens in the immune system has its reflection to something that happens in the joint. So we'll discuss about what happens to the immune system. We discussed genetics, PAD4 mutation, PTPN22. We discussed environment, smoking and microorganisms that can cause citrullinated peptide. All these contribute and they alter the antigen, causing antigen presenting cells to produce self-antigen. When antigen presenting cells are bound to self-antigen, the T cells which bind to the antigen presenting cells become autoreactive. So what happens? The T cells will identify the self-antigen as foreign and go for and produce effector T cells, which send interleukins, which change into effector T cells. These effector T cells secrete interleukins and stimulate macrophages and B cells. Macrophages in turn secrete the famous TNF-alpha, as we previously discussed in ankylosing spondylitis. TNF-alpha is a molecule which causes cachexia, which causes fever, which prevents bone formation, which causes capillary leak syndrome, shock, multiple and enhanced cytotoxicity. So this molecule, TNF molecule, is produced in excess, and B cells, which are stimulated by the T cells, produce autoreactive antibodies. So we have excess TNF-alpha, we have excess self-reactive antibodies, which cause the further changes in the joint. What happens to the joint? Now the joint is lined by the synovium. The joint cartilage contains cartilage, the synovial fluid, the synovium. The synovium is the internal environment, maintains the internal environment within the joint. What are the types of cells in this lining of the joint, the synovium? There are two types of cells. One is type A and type B. Type A is macrophage derived. It does the dirty work of targeting the microorganisms. But type B is fibroblast like synoviocytes, which secrete collagen, which secrete hyaluronan, which secrete the matrix required for the cartilage, the matrix required for the synovial fluid. All these is being secreted by the type B synoviocytes. Now what happens? There is chronic inflammation in the blood. There is excess TNF-alpha. There is excess autoreactive antibodies. This chronic inflammation, chronic damage that is coming inside the joint because of the TNF-alpha and autoreactive antibodies will give rise to pannus, a thickened fibrovascular tissue that contains these synoviocytes. Which synoviocytes? Type B synoviocytes. Type A synoviocytes does another damage. Type B synoviocytes is within this pannus. This type B synoviocytes containing pannus, containing B cells, antibodies, will invade the cartilage and bone and damage the cartilage and bone. And the type B synoviocytes will further secrete multiple matrix tissues, matrix components, and it will produce vascularity of the joint environment. But type A synoviocytes will activate the osteoclasts. The macrophages or osteoclasts are actually modified macrophages. So osteoclasts and cause diffuse osteoporosis surrounding the joint. So what happens? The inflammation outside the joint causing excess TNF-alpha autoreactive antibodies will damage the lining of the type A and type B synoviocytes. Type B synoviocytes will proliferate and cause a pannus, which this pannus also contains T cells, B cells. They will invade the cartilage and the bone and damage the cartilage and the bone. Type A synoviocytes, which are macrophage-like synoviocytes, will activate to become osteoclasts, which will again cause diffuse osteoporosis around the joint. This is the mechanism of how rheumatoid arthritis develops symmetrically and progressively, causing deformities and damage to the joints. Now the most important factor is the fire is set in the blood. The fuel is actually available inside the joints in the form of synovium. When the fire is becoming bigger, the fuel will cause a spread of the fire inside the joints and cause a multi-systemic, multi-joint involvement. How to diagnose rheumatoid arthritis? There is seronegative and seropositive rheumatoid arthritis. Seronegative is one which is negative for ACCP and rheumatoid factor antibodies, whereas seropositive is positive for ACCP and rheumatoid factor antibodies. If it is positive for the rheumatoid factor antibodies and ACCP, it means the disease will have a worse prognosis and a faster progression. If the patient is positive for CRP and if the ESR is very high, it means the patient will progress to severe disease very soon. So all this works as prognostic markers also, not only diagnostic markers. ACCP is anti-cyclic citrullinated peptide, as we already discussed, which has greater specificity than RF with 95% specificity. Rheumatoid factor, it is IgM or IgA or IgG against Fc portion of IgG. It has poor sensitivity and poor specificity, but the sensitivity is similar to ACCP. The sensitivity is 75 to 80%. The sensitivity is similar to ACCP, but ACCP is 95% specificity. Rheumatoid has very poor specificity. Hence, it is not the final word in diagnosing a patient with rheumatoid arthritis, because it is also seen in subacute bacterial endocarditis, hepatitis C virus infections, hepatitis B virus infections, systemic lupus erythematosus, cryoglobulinemia. All these conditions have a flurry of antibodies in the blood. So it is rheumatoid factor is positive in these conditions too. So it cannot be dependable for the diagnosis of rheumatoid arthritis. But if the patient with rheumatoid arthritis is diagnosed with RF positive, it means the patient will have a severe disease. Treatment of rheumatoid arthritis. The first line and the first choice is the wonderful drug methotrexate, which was developed decades back, and is still the cornerstone of therapy for rheumatoid arthritis. The maximum dose is up to 25 mg per week. It releases adenosine at the slow doses, causing an anti-inflammatory effect, and prevents radiological progression aggressively. But the famous drug hydroxychloroquine sulfate, reserved for mild disease and does not reduce radiological progression. The patient who develops flares are treated with glucocorticoids and stopped immediately as soon as the flares improve, because glucocorticoid can again cause osteoporosis. Whereas rheumatoid arthritis, osteoporosis is central to the progression of rheumatoid arthritis. The newer molecules like TNF-alpha inhibitors can be used in rheumatoid arthritis when it can be used in combination with DMARDS like methotrexate, sulfasalazine, leflunomide, or it can also be used when DMARDS have poor tolerance for the patient. When the patient is poorly tolerating the DMARDs, the disease modifying anti-rheumatological drugs. The other DMARDs are sulfasalazine and leflunomide, which are also used in patients who respond very well to DMARDs. Other drugs which have proven very useful are monoclonal antibodies like tocilizumab, which is against IL-6 receptor, and rituximab, which is anti-CD20. Now I would like to summarize about rheumatoid arthritis. Rheumatoid arthritis is a chronic systemic inflammatory disease that is characterized by symmetric polyarthritis and extraarticular manifestations. Most commonly involved joints are small joints of hands and feet. Most commonly metacarpophalangeal joints and in the hands and the metatarsophalangeal joints in the feet. It involves joints, tendons and bursae, the extraarticular structures too. And one joint which is of significance is the atlantoaxial joint, which can cause subluxation and neurological deficit. There are several deformities like the ulnar deviation, the Pianocchi deformity, the swan neck deformity and the Botanier deformity. Extraarticular manifestations are subcutaneous nodules, rheumatoid vasculitis, pleuropulmonary manifestations like ILD and pleural effusions, lymphoma. Genetics risk factors are citrullinated peptides. We discussed about citrullinated peptides. PAD4 and PTPN22 mutations play a central role in the progression of rheumatoid arthritis. And the pathophysiology, we discussed that genetics and environment collude or individually can cause autoreactive T cells which bind to antigen presenting cells which present with self antigens. The self antigens are usually altered arginine containing peptides which becomes citrullinated peptides. The citrullinated peptides are bound by antigen presenting cells which are produced to the T cells. The T cells interleukins and stimulate both the macrophages and the B cells. The macrophages give loads of TNF alpha, whereas the B cells produce autoreactive antibodies which trigger the systemic inflammation. Due to ongoing systemic inflammation which causes increased TNF alpha and autoreactive antibodies which enter the joint reacts by forming a pannus, and the pannus is constitutive of type B fibroblast-like synoviocytes which invade the cartilage and the bone. The type A synoviocytes transform into osteoclasts and cause diffuse osteoporosis. So diagnosing it requires the classical presentation like symmetric polyarthritis and the presence of antibodies such as ACCP, anticyclic citrullinated peptide, and rheumatoid factor. Treatment is with the help of DMARDS, disease modifying anti-rheumatological drugs like methotrexate, leflunomide, sulfasalazine, and hydroxychloroquine and glucocorticoids. Whereas the biologicals that can be used in this condition are TNF alpha inhibitors like infliximab, certolizumab, adalimumab, golimumab, and IL-6 inhibitors like tocilizumab and anti-CD20 like rituximab have also been proven useful. Thank you.
Docemy.